Hello everyone, myself Mahakash Rakshit. I'm a second year of MBBS student from Neelratan Sarkar Medical College and Hospital. So you guys are going to give your MD very soon. Before that, we are trying to discuss a little some questions of previous years university questions, right? So today I will be discussing the explain valves of head neck region. Okay, let's start. And we are trying to hit 1K subscribers in our channel. So if you like our videos, please do subscribe. Thank you. So the dangerous area of face. So this region of our face is called the dangerous area of face. The upper lip, lower part of the nose, and the adjoining cheek portion. Let's have a diagram. Here is the dangerous area of face. Why is this called the dangerous area of face? Because this region is drained by facial vein, and the facial vein lies just on the muscles of facial expression. And as the muscles of facial expression contracts and moves, the blood flow in the facial vein can be reversed in direction. That is called retrograde blood flow. And if the retrograde blood flow happens, there is a connection with the pterygoid venous plexus with the facial vein by deep facial vein. And the pterygoid venous plexus is again in communication with the cavernous sinus by emissary veins. Okay, and one more route is there via the angular vein and the superior ophthalmic vein, and then to the cavernous sinus. So if there is any retrograde blood flow in this facial vein, the blood may go to the intracranial cavernous sinus. Okay, so if there is any injury in this dangerous area of face, the thrombus formed or the infection may go to the cavernous sinus and may cause the cavernous sinus thrombolism. Okay, so that is why this is called the dangerous area of face. So first question is done. Now let's go to the second question. Posterior cricoarytenoid muscle is the safety muscle of the larynx. Why? Because all other muscles of the larynx except the posterior cricoarytenoid muscle helps in adduction of the vocal folds. You know what is adduction of the vocal folds? Let's have a diagram. Here is my diagram. Here the muscle showed in green color is the posterior cricoarytenoid, and here this cartilage is the arytenoid cartilage, and this is the muscular process. This posterior cricoarytenoid is attached to the posterior surface of the muscular process of the arytenoid to the posterior part of the cricoid bone. So as this muscle contracts, this pulls this muscular process posteriorly, and as a result, these vocal folds go away from each other. It is called the abduction of the vocal folds, and thereby allowing the air flow. The rest, all the muscles help in adduction of the vocal folds. So if there is any injury to this muscle, or if this muscle cannot work, then the vocal folds will come together, will get adducted, and the airflow will get compromised, and the patient may die also. That is why this posterior cricoarytenoid muscle, being the only abductor of the vocal fold, is called the safety muscle of the larynx. Right? Okay. Let's go to the next question. Dry mouth in fracture spine of the sphenoid. Okay. The spine of the sphenoid is related to two nerves. Laterally, it is related to the auriculotemporal nerve. Laterally, auriculotemporal, and medially, cauda tympani. Now, you guys very well know that the auriculotemporal nerve gives secretomotor to which gland? Parotid, right? Parotid gland. And this cauda tympani gives secretomotor to which gland? Sublingual and submandibular. Now, kindly note that if the spine of the sphenoid gets fractured, then both of these nerves may get injured, and if these two nerves get injured, then the ipsilateral, all the three salivary glands, that is the parotid gland, submandibular gland, and sublingual gland, fails to secrete saliva, and as a result, there is dry mouth. Right? So this is very. One of my students have written this answer very nicely. I would like to share this with you. You can take a screenshot and read it. Okay. Here is the answer. Now see, thyroid swelling moves with deglutition. Why thyroid swelling moves with deglutition? Let's have a diagram plus first. Here is the sagittal section. It is the sagittal section of our neck region. Here is the thyroid gland. Here is the thyroid gland, and this green colored thing is the pretracheal layer of the deep cervical fossa. Pretracheal layer of the deep cervical fossa splits to enclose the thyroid gland. Okay, and then it gets attached to the oblique line of the thyroid cartilage and ultimately to the hyoid bone. And in the region of the lobes, the medial side of the lobes of the thyroid gland, this pretracheal layer of the deep cervical fossa thickens to form a suspensory ligament of Berry, which connects the first capsule of the thyroid gland to the cricoid cartilage. Okay, now you guys try to imagine that, try to understand that whenever we swallow, right? See, whenever we swallow, this muscle forming the floor of the mouth contracts. This is called the mylohyoid, and mylohyoid gets attached to the hyoid bone, right? Here is the mylohyoid muscle, it gets attached to the hyoid bone. So whenever we deglute or swallow, it moves the hyoid upwards. As soon as hyoid moves upwards, this pretracheal layer of the deep cervical fossa moves upwards, and as a result, the thyroid will move upwards. Okay, so with respect to as we swallow or deglutition is done, the thyroid moves up and down. So this is one way. What are the another ways? Look, this thyroid false capsule of the thyroid made by the pretracheal layer of the deep cervical fossa splitting is attached to the cricoid by ligament of Peary. Okay, now as the hyoid moves up, this thyroid membrane also moves up. This pulls up this thyroid cartilage. This pulls up this cricoid. This one is cricothyroid membrane. So cricoid also moves up, and ligament of Peary pulls the thyroid upwards. Okay, so as we swallow, the thyroid moves up and down due to these movements, right? Let's go to the next question. Left recurrent laryngeal nerve hooks around the ligament of arteriosum, and right recurrent laryngeal nerve hooks around the subclavian artery. Why this collaborating? This is a very interesting question. Let's see. You guys say, what is the nerve of sixth pharyngeal arch? Nerve of sixth pharyngeal arch is recurrent laryngeal nerve. Okay. Let's have a diagram. Okay. Think this is my sixth pharyngeal arch. Above there is fourth pharyngeal arch. Okay. Why fourth? Because there is no fifth pharyngeal arch. Fifth pharyngeal arch degenerates. Okay. And here is my this is my midline. This is the midline, and see, this is the red color thing is the sixth pharyngeal arch artery, both sides, this side and this side. Okay, the medial portion of the sixth pharyngeal arch artery helps in the formation of pulmonary arteries. Okay, and the lateral portion, in case of left side, it forms the ligamentum arteriosum. And in case of the right side, the proximal portion will form pulmonary arteries, and the lateral portion forms nothing. So here was my recurrent laryngeal nerve hooking around. So as in case of the left side, the sixth pharyngeal arch artery is forming ligamentum arteriosum. Left recurrent laryngeal nerve hooks around ligamentum arteriosum. As in case of the right side, there is no structure forming from the sixth pharyngeal arch. It will move upwards and it will hook around the structure derived from the fourth pharyngeal arch artery. And what is that? The structure which is formed from the fourth pharyngeal arch artery is right subclavian artery. Okay, that is why left recurrent laryngeal nerve hooks around the ligamentum arteriosum, and the right recurrent laryngeal nerve hooks around the right subclavian artery. Got it? Nice. Now let's go to our next question. What is the next question? Aren't they very easy? They are very easy. Okay. Increased pressure of the CSF in subarachnoid space is easily diagnosed by ophthalmoscopic examination of the eye. Let's see a normal ophthalmoscopic examination of eye diagram. Can you see this one, a cup-like structure, very light color contrast is very clearly seen. This very clear-cut margin is seen. Okay, this cup-like structure which is seen is called the optic cup. Okay, this is the region of the optic disc, right? If there is increased CSF pressure, what happens? Let me show you. This happens like this. This happens like this. There is no clear-cut margin. You cannot see the clear-cut margin, and the structure of cup, optic cup, is no more there. Why is this happening? Why is this happening? This is happening because I need one more diagram. Yeah, it is a diagram showing the eyeball from the behind. Okay, and this is the point from where the optic nerve is getting formed. Okay, so here these are the nerves. Okay, fibers, nerve fibers. And if you see the cross section, there is the arachnoid, and this is the subarachnoid space. So the optic nerve itself is having the subarachnoid space around it. So increased CSF pressure will be here also in this subarachnoid space also, and this subarachnoid space of CSF will push this portion towards the vitreous humor, okay, of the eyeball. And this, can you see this cup-like structure? And this will push this optic disc inward, and the cup-like structure will get destroyed, right? So this is how we can easily identify whether the person is having increased CSF pressure or not by just a simple ophthalmoscopic examination, right? Let's see the next question. Parotitis is very painful. Why? Why parotitis is very painful? If you have read anatomy all the year, you will know that any pain is painful when there is something trying to expand, but something is preventing it from expand. Something same is happening here, right? The parotid gland is covered by false capsule and true capsule. True capsule is by its own stroma, but the false capsule of the parotid gland is formed by the deep cervical fossa, splitting of the deep cervical fossa. Okay, as the deep cervical fossa splits to enclose the parotid gland, let's see a diagram. Why not a diagram? Diagram is very important. Here, your favorite Visram Singh books diagram. Okay, here is the investing layer of the deep cervical fossa. You can clearly make out it is splitting in two layers to form the false capsule of the parotid gland. The anterior, the lateral one is going to attach to the zygomatic arch, whereas the posterior one to the tympanic plate. Okay, now the lateral layer of this false capsule is getting attached or blended with the epimysium of the masseter muscle to form a very tough fossa called parotidomasseteric fossa, right? Parotidomasseteric fossa. This parotidomasseteric fossa prevents this entire false capsule is becoming an unyielding or something which does not provide any expansion, right? This unyielding fossa layer prevents expansion of the parotid gland. So, if there is any inflammation of the parotid gland will try to swell up, and this fossal covering will prevent it. As a result, there will be enormous pain. That is why parotitis is very painful. Got it? Okay, the next question. A child suffering from acute tonsillitis mainly complaint of pain in the ears. So the tonsillitis is here and the person is feeling pain here in the ear. Why? Because the tonsil is supplied by glossopharyngeal nerve. And if you see, you will get to see that in the ear, the medial wall of the ear, there is a promontory, the elevated portion, which is called a promontory. On the promontory, there is a tympanic plexus of nerves, right, which supplies the middle ear cavity. Okay, this tympanic plexus of nerve is contributed by this tympanic branch of the glossopharyngeal nerve. Okay, as the middle ear cavity and the tonsils are getting same nerve supply, so the pain of the tonsillitis is referred to the middle ear cavity. Got it? This is a plain and simple answer, right? Next question. Pain is referred to the middle ear in ulcer of the posterior part of the tongue. Very easy, just like the previous question. The posterior part of the tongue, posterior two-thirds of the tongue is supplied by which nerve? Both taste sensation and the general sensation by glossopharyngeal nerve. And the tympanic branch of the glossopharyngeal nerve supplies the middle ear cavity by the tympanic plexus. So the ulcer pain of the posterior part of the tongue will be referred to the middle ear cavity. Plain and simple answer. Okay. Same nerve, one region is getting affected, the pain will be felt in the other region. This is the concept of referred pain. Very easy. Achha. Next question, in tonsillitis, pain is referred to the middle ear cavity. Done. Superior parathyroid are inferior in position. Why? As you can see in the diagram, that the inferior parathyroid is getting developed from the third pharyngeal pouch. Okay. What is pharyngeal pouch? The endodermal deep portions between two consecutive pharyngeal arches. Those are called pharyngeal pouches. So from the third pharyngeal pouch, inferior parathyroid and the thymus develops, right? And from the fourth pharyngeal pouch, the superior parathyroid develops. That is why superior parathyroid is also called as parathyroid 4. And the inferior parathyroid is also called as parathyroid 3, right? But as the inferior parathyroid is developing along with thymus, what is the final location of thymus? Thymus is located in the middle mediastinum, that is in the thorax. So the thymus will descend down from this pharyngeal region to the thoracic region. When it will descend down, it will hold the inferior parathyroid along with it and will make it descend down also. So the inferior parathyroid or parathyroid 3 will descend more below to the parathyroid 4 or superior parathyroid. So according to the final location, the superior parathyroid is superiorly located and the inferior parathyroid is inferiorly located. But if we want to see the development, we will find that the inferior parathyroid develops more cranially, that is from the third pharyngeal pouch, whereas the superior parathyroid develops caudally, that is from the fourth pharyngeal pouch. Got it? Very easy. Done. Let's go to the next question. What is the next question? Optic disc in eyeball is known as blind spot. We know it from very beginning, from 11 or 12, that in the region of the optic disc, all the nerves of the retina come to one spot and form the optic nerve, right? And in this region of the optic disc, there remains no rod or cone cells. Those rod and cone cells are actually the photoreceptors. One is for black and white sensation, and cones are for color sensation, color vision, right? So as in the region of the optic disc, there is no rod or cone cells. It is not sensitive to light, so this cannot see anything. That is why this is called a blind spot. Plain and simple. What is the 14th question? Posterior inferior quadrant of the tympanic membrane is chosen for myringotomy. Myringotomy means you will give an incision in the tympanic membrane for any surgical procedure. That can be drainage of pus from the medullary cavity also, right? So in case of myringotomy, you will have to find a location in the tympanic membrane which is safe to cut. What does that mean? There should be no important neurovascular structure, right? So that free of neurovascular structure in the tympanic membrane is the posterior inferior quadrant. In the posterior inferior quadrant of the tympanic membrane, there is no important major arteries or vessels, veins. That is why we can put a myringotomy in the posterior inferior quadrant of the tympanic membrane. Okay. Layer of loose connective tissue is known as the dangerous area of scalp. Why? We know there are SACALP 5 layers in the scalp: skin, connective tissue layer, aponeurotic layer, loose areolar tissue, and osteum, right? Pericranium. Let's see a diagram. Shit, I don't have a diagram. So if you see the diagram, you will get to see that this loose connective tissue layer of the scalp is in communication with the intracranial dural venous sinuses. Okay, as this layer is connected to the intracranial dural venous sinuses via the emissary veins, any thrombus formation in this layer may go to the intracranial dural venous sinuses and will lead to thrombosis, right? In the intracranial dural venous sinuses, that may be lethal. That is why this loose connective tissue layer of the scalp is also called as dangerous layer of the scalp. Next question: throat infection in child, if neglected, may lead to mastoiditis. Why? Throat infection in child. This is very plain and simple answer. Throat means pharynx. Think about the nasopharynx. In the nasopharynx, we find the opening of the eustachian tube or auditory tube, right? From the nasopharynx, the auditory tube is in connection with the medullary cavity. Here you can find that this is the auditory tube. This will get opened in the nasopharynx, lateral one. Nasopharynx. So if there is infection in the nasopharynx, it will go from here to all the way here in the medullary cavity. So nasopharynx infection may lead to infection in the medullary cavity. Now this medullary cavity is in communication with the mastoid antrum. This is called a mastoid antrum via adductus to the antrum. Okay. And this mastoid antrum again in communication with the mastoid air cells. So the infection of this mastoid antrum and mastoid air cells is called the mastoiditis. Okay, inflammation of the mastoid. So the nasopharynx infection may go via the auditory tube or eustachian tube all the way to the medullary cavity, and then via adductus to the antrum to the mastoid antrum and the mastoid air cells. This is the route of spread of infection from the nasopharynx to the mastoid antrum and mastoid air cells, leading to mastoiditis. So this was all about the previous year's West Bengal Health University questions, explain why questions from headline. Thank you. If you like the video, please hit the like button and do subscribe our channel, and don't forget to share this video with your friends.